But now I'd like to introduce a very special friend of our organization and who I think is one of the thought leaders in this field. Her name is Candy McCabe, and she is a consultant nurse, and she leads a multidisciplinary clinical research team that provides a national referral service to those with CRPS in the UK. And I know when anyone in England, Scotland, Wales, or Ireland calls me, I give her name. And she is a grantee from us, and she'll tell you about a study that we're doing. It's the largest funded study that we've ever done. And we're so excited that she's here. And Jenny Lewis, her colleague, will be in the afternoon. But thank you. And Dr. McCabe.
Thank you very much indeed. First of all, I'd like to say a huge thank you to Jim Broach and his colleagues on the board of RSDSA. It's a real privilege to be here today amongst you all, and also, speaking to the online community as well. That's just fantastic. And I would like to send my congratulations to Jim and his colleagues at RSDSA for organising this event, but also for all the hard work that they do. We in the UK use their website a huge amount and often direct our patients to the RSDS website, simply because it's always up to date, it has really sound, sensible information on it, and there's so much on the internet that is scary, that's inaccurate, and you can always trust the resources that you get on RSDSA. So I'd just like to send my thanks to them, and just delighted to be here. This is my disclaimer up here. You haven't had CRPS and you can't really envisage it. This was what was said to me by one of the carers of a person that we were caring for. And I think I was really aware of this statement as I wrote this presentation. I don't have CRPS. I can't envisage it. I work with colleagues and patients with CRPS every day back in Bath. We've done that for the last 12 years. I have a reasonable idea of what you and your families are suffering, but I have never had unremitting pain day in, day out. And my family can tell you that if I have a headache for more than a couple of hours, it's time to leave the house. So I really admire all of you for turning up, sitting here, and also all the people that care for you. So this is my disclaimer, and I hope that in my presentation I've said things that are thoughtful and are appropriate, but sincere apologies if not. So things I want to cover. I thought you'd want to know what the health professional's view is of CRPS, and in particular, what we do know, sadly what we don't know, and what are we doing about it? How are we being busy to try and help all of you here? I thought also the carers are really important, and we've done some work in Bath looking at the carers' perception of CRPS, and I thought that may be useful for you. And then most importantly, where does all of this leave you? And again, we've got some advice from patients to patients, which I thought may be interesting. And then just a summary of what I've covered. So let's start with the health professional's view. You can see this is pretty much the state of where we're at. At the top of that iceberg, that little tip, is what we do know about CRPS. And I'm afraid there's a whole load below the waterline of which we have very little idea about. And that's our problem, and that's exactly what Jim was alluding to, saying that ever since the 1800s, when Weir Mitchell was describing this condition, we actually haven't moved on a huge amount beyond those days. But we're doing things. So these are the things that we do know about CRPS, and I've kept these very general because these are the facts that are solid. So we do know that it's a multi-system syndrome. It influences the immune system, the nervous system, and the vascular system. So your blood supply gets disturbed, and you're really aware of that when your limbs become either very hot or very cold, and that's your vascular system overreacting or underperforming to accommodate those changes in the environment around you, and also the stresses that you're undergoing. That'll make your limb change colour and temperature. And of course, your nervous system is totally involved in all of that you're experiencing. We know, of course, that both adults and children are affected with CRPS. But fortunately, we know that actually children recover from this condition far more quickly, and usually is more common that they will do very well from this condition. Unfortunately, there are a few who continue on to have symptoms into adulthood. But it looks as if it's a subtly different condition than adults. We also know that actually the vast majority of people make a full recovery from CRPS within the first year. Now, I know that's really difficult to believe, because actually we rarely even see these people in our clinical practice, because their symptoms are such that they're mild, that they're self-resolving, or that in fact just early physiotherapy will correct that. So actually about 85% of people who contract this condition make a full recovery within the first year. But then, of course, there's a significant percentage, that 10–15%, who go on to get long-term chronic problems. And that's the group that we really need to help. And that's the group that we're most aware of, because that's the population that's coming to our clinics. We also know that the age of onset is normally around middle age, and it's far more common in women, about a 3:1, 4:1 ratio of female to men. We don't quite know why, but that's quite common in other musculoskeletal conditions too. So perhaps that's a little pointer for us, an indicator of where we should be looking for what causes CRPS. We also know that early diagnosis and prompt treatment is actually the best thing that we can have. And that's really important for us to think about in terms of education initiatives, so that we can tell people about this condition, get them to pick it up quickly, recognize it, treat it.
They're having trouble hearing in the back.
Okay, I'll shout louder. Thank you. Thank you for letting me know. We know too that keeping that painful limb moving is particularly important, and really important in the early stages. So although it feels very against what you want to do, moving a painful limb, it's really important to keep it as functionally active as possible. Increasingly, we're starting to learn that we need a multidisciplinary approach to care. We need to, of course, have help from the medical community in terms of medications, types of nerve blocks, those sorts of things, but also the other members of the team, your physiotherapist, the occupational therapist, psychologist, really important. This is a multi-system syndrome, so you need a multi-system, multidisciplinary team to care for you. But crucially, most importantly, we know that if we can equip patients with the skills to self-manage their condition, have the confidence to get back in control, we can improve quality of life. And we know that from a whole range of different chronic conditions, that the person at the center of all of this, the person with the condition, if we can upskill them to help manage their condition, that's where we'll have our greatest success. So this is the magic wand. If we could sort out CRPS tomorrow, these are the key facts we would need to know. We'd need to know how it presents. So what are the key presenting signs and symptoms? We'd need to know the precise cause. We'd also have to know who it affects, as in what type of person, what do they look like? How the symptoms develop over time, what's the natural course of this condition? And what recovered looks like. So when CRPS is gone, when you're feeling better, how does somebody then look? And to make this very simple, if you start with a common cold, and you know pretty much how long it'll going to last, what sort of signs and symptoms you'll get, what sort of treatments you'll take to make it better, and what you know at the end of that when it's gone. All very straightforward, and that's how we usually start with a condition. And that's what we need to know in CRPS. And also we need to know, even when we know the cause, is it something we can modify? Is it something we can change? So I'm afraid we're now merging down below that tip of the iceberg. We're down into the icy cold water below that iceberg. And these are the things we don't know. We don't have a magic wand, because unfortunately, we do not yet know the precise cause of complex regional pain syndrome. We don't know what risk factors reliably predict who's going to develop complex regional pain syndrome. So if somebody has a fracture, we can't say on the day that they have a fracture, yes, we should be treating you like this and you like that, because the first person's likely to get CRPS, but actually the other person isn't. We don't have that information. We also don't know who's in that 80% who's going to get better spontaneously and who isn't. Therefore, how do we select out which people need that really quick, intensive treatment? So that we still need to identify. Even once we've identified it, we don't really know which treatments are the most effective, at the time point we should be using them, whether actually we need a combination of treatments, and again, what each person looks like who'd do best from particular treatments. Because you will all know, you'll all have a very common story, but actually underneath that common story, there are a huge range of individual variances, subtle differences in your condition, and therefore you will all respond to a slightly different way with each treatment. And I'm really aware from the chat rooms that people will suggest something that they found really helpful, and then the next line comes on and says, actually, it didn't do anything for me. And we know that even with recognized common medications like pregabalin, gabapentin, only 1 in 3 people get benefit from those drugs. So there's a lot about individual tailored treatments that we still need to find out. And importantly, we need to know what recovered from CRPS looks like. So the consequence of all that unknown is that actually many of you wander around in a maze. You may move from one doctor to another, initially just trying to get a diagnosis. You have this strange collection of symptoms. Maybe your family doctor's never heard of it. They disbelieve that you can possibly have such a wide range of unpleasant sensations. And so they may send you on to a different specialist, who likewise may disbelieve you because they haven't heard of it. And certainly in the UK, our patients tell us that they wander through this maze of different specialists, trying different drugs, seldom have somebody else to talk to with the same condition, to just touch base and say, actually, I'm not mad, am I? This is real. So we need to sort out this maze. We need to unpack it, and we need to get to a nice straight line from the point that we know when this condition starts, we know when it finishes, and we know that journey in between. Ideally, what we'd love is that we knew even before that start of that road, that we could predict who was going to get this and stop it in its tracks. We'll have to see how that journey goes, but we need to get rid of this maze. So what are health professionals and academics doing to try and improve customer service, to try and make things better, to try and sort these problems? We're doing a huge amount, and some of it may not seem as if it ever reaches anything that you will see. But there is, I promise you, a lot of work going on internationally in a whole range of different universities and hospitals, trying to unpick that maze. People looking at the very basic science of research, trying to work out where in the immune system the problems are going wrong. Other people looking at, once the condition arrives, how can we best treat it? What are the symptoms that best respond to this particular treatment? What does this person look like who would respond best to this treatment? How does it differ between children and adults? What does that tell us about how the brain develops over time? Is it important that actually children on the whole get better? Is that something to do with their brains being developing brains? Is that important? We also look at how we're actually doing in delivering the care that we're doing. So lots of audit, checking with patients, whether we're doing the right things. And what I think is the biggest change over the 12 years or so that I've been working in CRPS is that in many of these projects, we have patients just like you involved in that project. So we make sure we're keeping it related and relevant to people with CRPS. And that's a huge advance and can only be for the good. So I want to tell you about some specific things that I know about that is happening. And it has to be said that there's a huge amount that I've not included here. So these are just topics that are close to my heart. So 3 weeks ago, I was fortunate enough to be in Milan. The International Association for the Study of Pain have their meeting there, runs every 2 years, and it brings together all the clinical and the academic and the basic scientists working in the field of pain, covering every sort of topic. But within the ISP, there's a special interest group just for CRPS. And that has been previously led by Dr. Joshua Prager, who's in the middle of this slide with his T-shirt on. And he organized a 2-day meeting for all the great and the good in the CRPS community to get together to start to see how we can update the treatment pathway that's currently published by the ISP. How can we make it better? When it was first published, there were a lot of treatments that now perhaps have become outdated, but also new treatments have come online. Our understanding of the mechanisms is starting to advance. So we need to accommodate that into a new treatment algorithm. So Joshua convened this group, and the work is still ongoing from there. So this is the current ISP treatment algorithm. It's quite a funny shaped thing, but effectively it just sort of shows 3 arms to treatment. And you can see that on the far left, there's one all about the pharmacological management and types of medications. And then on the right, the sort of interventional pain type things. And then down the middle, it's much more the multidisciplinary interventions, such as stress loading was topical at that time, using hydrotherapy. And it's this particular algorithm that we're now in the process of updating, with the hope of creating some treatment principles. What is it that each person with CRPS should get when they are first seen by a clinician? And how will that pathway change over the course of their condition? What treatment should they be getting based on best evidence how their pathway should look? Once that's published, that will go up on the ISP site. I have lobbied that we have a patient version. When I first muted this, there was a little look of horror and said, why would patients be interested in this? So I'm pretty confident you'd be really interested in this. So we hope to publish this very much in a patient version as well, and perhaps that's something that RSDSA could work with us on.
Well, why can't we have this one? I can understand this.
This one needs updating. Things have changed over time.
Well, the one that you're doing, what's the difference between the updated version and the patient? What would be the difference?
Shall I show you? We are at the moment, we're using the updated version is being informed from very new treatment guidelines that have been published by different countries. So the UK has just published one this year, and you can access that through the Royal College of Physicians website. That has the whole, that's the Royal College of Physicians website, which I can give to Jim afterwards and we can send around. That'll give you access to the whole of the UK treatment guidance. There's also the Dutch guidelines. That's a much weightier, bigger document. May not be, I mean, it's very good, but it may find it a bit more difficult to access. But from those, we're looking at reworking perhaps our treatment principles, so that we still make sure that it's a multidisciplinary approach, so that we are very sure that we need to have medications and those sorts of interventions. We need to have physical and vocational rehab. We need patient information and self-management, education, really important. But each of these pillars from that original treatment algorithm just needs updating. We need to get into, the original one was done about 2004, so it needs updating. Things have moved on.
But my question is, why would there be a difference? Why would there be a difference between the when you give the patients and the when you give the doctor?
The only difference would be that the terminology, some of the jargon that's used in the medical world is for some of us it takes some explanation. So I think we could provide a far more user-friendly version that would be more useful for patients to follow. So that's the only reason. That said, it may not look a whole lot different. At the moment, it's still in the development. But yeah, we're just aware that sometimes what we speak is, it's difficult for even us to understand. So it's important that it's communicated in a sensible manner. Does that help?
At the same time, that's something that the doctor would say, or so we become familiar with it, or we see it on a website, and so we probably know it just as well.
Absolutely, absolutely. No, I completely. I think it's for those who, when they're very first diagnosed, that terminology is less familiar to them. Is that okay?
Oh, absolutely.
Yeah.
Absolutely. sorry.
No, that's fine. No worries. Okay. I also wanted to tell you a little bit about the RSDSA funded research, which Jim mentioned. And this, I think, is going to be hugely important for the future direction of where research goes to. So I said at the beginning that one of the key things we need to know is what recovered looks like. How do we know when somebody with CRPS is recovered? And let me just explain that to you a little bit more about why that's important. For those people who have very early onset CRPS and their symptoms settle very quickly, they will be very aware that actually what they feel is recovered is when they're back to the state that they were in before this ever started. So they have no problems at all. They're completely back to how things were before. But equally, recovered may look like somebody who's got long-standing chronic CRPS, and we have a patient who's working with us on this study. She says, well, actually, I consider I'm recovered from CRPS. She still walks with a stick. She still has a very painful foot, but she's back working. She's doing all the activities she wants to do. She says, I'm in control. I feel I'm recovered from it. So there are different standards of recovery at different time points throughout the condition. Equally, when we come to do clinical trials of new treatments, we may find that trying to work out how somebody's recovered from this will be different for each population. And until we know a definition, it's very difficult for us to measure success against that. So,
how would you consider somebody walking with a cane being back to the former stage of not walking with a cane, having recovered? I don't understand that.
If we could just hold our questions, because I think it will come out.
absolutely. And actually, that's a really good question, because what we wanted to do was go to the patients and ask the patients their perspective of what recovered is. So we haven't assumed anything as health professionals. And there's a group of us across 8 countries. And so that's the UK, and then we have the Netherlands, Denmark, Poland, Germany, Switzerland, Canada, the United States, all working together. We have academics, health professionals, and patients who have been very generous with their time, and they are working as part of the research team. So Helen is one of our expert patient researchers from Canada, and we are working together to create a questionnaire which will be sent out in each of those countries to ask patients to tell us what their definition of recovery is, what it means to you to be recovered. We will then send out a second questionnaire using the information we've gained from that first one, asking people to tell us, in order of the themes that have come up in that first questionnaire, what are the important things that you would like recovered first? What are your priorities for recovery? So that we know that when we come to devise treatments in the future or research studies, we know we're aiming at the top things that you need sorting first. So it's very much you telling us what your definitions are, you telling us what your research priorities are, so that we can then move on from that. Now, the most exciting thing is that this is an international network. CRPS is actually a very rare condition. Relatively, it's not that common. Therefore, in order for us to do good studies like this, it's crucial that we all work together as a network, as a team. And our biggest problem is language differences. So for this study, where we've got 8 different countries, we're translating all our documentation into 8 different languages. But that means that job's done. We can then continue to work together as a network, advancing the research into CRPS. So I'm hoping that from this study, a lot will come from it. The other beauty is that the expert patients, we now have 8 countries all linked together who have their own patient support groups who are also now talking and sharing information. And that's really helpful. So where will CRPS research go to in the future? I think, to my mind, we have to do this on an international basis. And Jim's already talked about the fact that we need to bring together communities. It's really important. The International Association for the Study of Pain works in that model. RSDSA have started that network through the recovery study to also work in that model. And I'm really aware that they're bringing together basic scientists in the same sort of network structure. That will continue on into the future. I'm confident of that. We will also get smarter at identifying the risk factors for CRPS. We'll start to be able to predict who will get this condition. We'll get better at improving early diagnosis, be that through better education, educating our physicians, our health professionals as they go through their training. We're going to get better at doing that. We already have done in the UK just over the 12 years that we've been operating through lots of education initiatives. And I know RSDSA do a huge amount. We're also going to get smarter at identifying all those different subtypes of CRPS, how there's those individual variations, how people look in different groups. And that will help us to have more individualized, tailored treatments. And we're going to get better at evaluating treatments in a way that's meaningful to patients, asking you your opinions, making sure that it's research that's relevant to you, and that's just crucial. So I want to now have a think about from the carer's perspective. And I put this shadow because when I work in clinic, often the carer isn't present when I have the patient sitting there. But much of the conversation is about that support that this person sitting in front of me is getting from either their family, their friend, somebody who's close to them, who knows them intimately, who's been along this journey with them. And I think it's really important that we just have a look at how carers perceive their role in CRPS. So this was a study done by one of our PhD students, a lady called Alison Lauder, and working with other colleagues in psychology. And she just interviewed 12 people who were caring for somebody with CRPS. Some of them were related, some of them were the husband or wife, but otherwise, sometimes they were just a good friend. They were the closest person to this patient. I'm just going to put up some quotes just to demonstrate the different roles that a carer has. It was really apparent that carers just wanted to do the best, and that was really sometimes quite difficult. So it's very difficult. It's a very fine line that you're treading between nagging somebody and trying to encourage them to do the things that you know are going to cause them 10 times more pain. That was really difficult. So carers talked about the problem of getting people to continue with their rehab when it may have been not such a good day, or when they were exhausted with their pain. And just that fine line between encouragement and being a nag. They also talked about this, it's a balancing act, not pushing it too far, because I think if you push her too far, she can get stubborn and dig her heels in. We're all like that, aren't we? Not just special to CRPS, but yeah, a difficult line to tread. There was also this role about understanding the person really well and desperate to care for them. I don't think other people fully understand what she goes through, to be honest, on a day-to-day basis. They understand, but it's hard to explain to them, and for them to know what we're really going through on a day. And I know all of you can relate to that. I see somebody for an hour in clinic, and then over 2 weeks when they come as an inpatient, I see them intermittently throughout that 2-week period. I've never followed somebody for 24 hours through their day of getting up, getting dressed, having meals, getting yourself ready for bed, going out to do activities. But you all know that there are key people in your lives who do that day in, day out. They know exactly all that you're going through. I always make sure that I stay on her bad side, because I know to give her that little bit of room, because she doesn't know where the hand is and so on. So there was this protective side, this protective role, that they wanted to make sure that the person with CRPS didn't knock their painful limb, that they would just look out for them and make sure that they'd steer them down the street so they were not likely to get hurt. And then being an advocate for them, and that people talked about very passionately. I've started to get a bit short-tempered now with medical professionals who give you the blank look. I can understand it with ordinary people. So they wanted to make sure that medics really knew that this was a real condition, that the person that they were caring for was really suffering. They wanted to be their advocate, to voice the problems that they were having. And they also wanted to just make sure that they were getting the right treatment. I'm so armed with information. I said to the doctor, you're not putting it in a cast. I said, right, we need an air cast boot. That's what we want. So this was about somebody who had a fracture after they'd had CRPS, and the carer was very concerned that they weren't going to have it put in a plaster cast again, because that had been the original problem. So you will relate to these comments, I'm sure, very well, that there's somebody out there who's looking out for you, and they're passionate about looking out for you. They're passionate to protect you, care for you, make sure that they're there to speak up for you when things are not so good. So where does all this leave you? Where have we got to? So this was a study that a colleague at Bath, Karen Rodham, and 2 of her students did. Karen's a health psychologist. And her students asked patients, what advice would they give to other patients? These are patients who we've seen within our clinics in Bath. So these are people with long-term CRPS. And this was their advice. And they said, actually, the main thing that you need to get is control of your life. Said that that's sometimes very difficult, but that's where you should aim for. And they said the things that will help you to get control are 3. There's acceptance, gaining the right support, and becoming informed. And I just want to talk you through just a few of those. All of it, they said, some days you get right, some days you don't. So acceptance. This was advice from patients to other patients. I suppose the first thing that I would say to them is try not to constantly explain to people what you have got. When people say to you, how are you? Just say, I'm fine, thanks. How are you? Get to the point where you stop looking for a cure and don't let it run your life. Some of you will really relate to this. Allow yourself to cry. And don't be afraid to cry with others. You know, with your close circle of friends. I think at times I've shed enough tears for the half the world. So there's some tough, tough days. But don't be hard on yourself. Those days will happen. But you'll move on. Becoming informed. And today is all about becoming informed, isn't it? This is a fantastic way of meeting others and becoming informed. So I would say read up about it. I mean, you can over-read about it, but try and get a good source of understanding of the condition. Either read up about it or speak to somebody else that's got it. And I know when we bring our patients in for an inpatient stay, there's usually 3 other people there at the same time. And to be quite honest, I think if we just left those 4 people for 2 weeks, they would improve 100-fold without anything else that we did. Because just talking to other people with the condition seems to be hugely therapeutic. When I first looked it up on the internet, I did scare myself. There's some horror stories out there, aren't there? Some really frightening things. And I think there's many people who've logged things up there who don't even have CRPS, who tell all kinds of terrifying tales. It is very scary. Get to know about the illness and what works best for you. Because everybody's different, aren't they? And I know certainly, having cared for other people with chronic conditions, that it's a learning process, isn't it? The more you can learn about what your daily rhythms are, what upsets things, what you can tolerate at certain times, the easier your journey is. Gaining the right support was the other thing. So that was the 3rd point in helping you to gain control. And again, today is all about gaining the right support. I think everybody, or a lot of people with CRPS, all say the same, that they've lost their circle of friends. There'll be so many people that will go, you know, back away from you. And I think that is the most important thing that comes up in our first appointments, that many people have stopped working, they no longer have social interactions, and they've become really housebound. And you lose your self-esteem. I think that's a very telling statement. So it's important you've got people to talk to. And it's effortful, but it's really important to get out there, talk to people. To get a family doctor that you can talk to, because you feel like you're a nuisance. You feel like you're going over the same thing every time. And there'll be some months, I'm sure, when you feel you've been back there every day and said the same thing. And it's really difficult, isn't it, to keep restarting those conversations. It's important that you've got people to talk to, some sort of support network, whether that's friends that really do understand CRPS and aren't going to laugh at you because you've got sausage fingers, or whether it's professionals that you talk to. So finding the right people who relate to you, that make you feel better. Avoid all those who make you feel blue. You don't need them. You don't need them whether you have CRPS or not. You need to find people that you can relate to that make you feel good about life. So I guess the other thing I'd say is shift your focus. And I want you all just to put a finger, if possible, in front of your face. And I want you to really concentrate on that finger. And I want you to think, as you're looking at that finger, what else is going on around the room, and to try and look around the room with that finger right in front of your face. And then I want you to put the finger down, and then be able to look around the room and see what else is going on. And I suspect the second way is much easier to see what's going on out there if you haven't got something constantly in front of your face. So having your pain, having CRPS constantly in front of your face makes it very difficult to get out there. So it's shift your focus. All of that advice that our patients were saying to help you get back in control. Find a good support network. Make sure that you are able to keep this so that you've got people that you can talk to, you can rely on, and that CRPS isn't ruining and running your life. So I've talked this morning just about what health professionals and scientists are trying to do. I promise you there's a large number of people out there working very hard to try and find a cure and the best treatments possible for CRPS. And until we find that cure, we're going to make sure that we're treating you in the best way that we know, and making sure that's evidence-based, but most importantly, that it's making a difference to you. We can do all kinds of highfalutin research studies, but unless they make a difference to patient care, then it really isn't worth the effort. I hope you feel that there are people out there who are caring for you, who take that role really importantly. They want to do it for you. They feel that they are desperate to care for you, be an advocate for you, and act on your behalf, look after you. And finding the ways to help you gain control, focus on what is possible, can optimize your quality of life. We're so good in our clinics to focus on what isn't working, and perhaps not so good on saying, what's gone well for you this month? What have you succeeded in? What are you doing? And shifting that focus, both for health professionals and patients, should move us in the right direction. So finally, I guess I want to say is that we need to work as a community, that together there's a huge amount we can achieve. You may well recognize these two individuals from the recent Paralympics. So Daniel Brown, who's an archery sportswoman, and Rachel Morris, a hand cyclist. They both have RSD. Daniel Brown has it in her legs, and Rachel Morris, who's been a patient of ours for a number of years, she also had RSD in her legs, and unfortunately now has bilateral amputations. She got a bronze medal this year. She got a gold in Beijing 4 years ago. They are fantastic role models. When they've got up in the morning, they've thought, what's possible? What can I do? I'd like to just acknowledge my clinical and research colleagues at Bath. We are a multidisciplinary team in the broadest sense, and many of the, well, all of that I've shown you today couldn't have done without them. They are a fantastic group of people. And also to acknowledge all my external research collaborators. The group that you see down on the right are all those who were involved in the recovery study. So a wonderful mixture of international and UK-based colleagues. Thank you all very much. Thank you.